is the sonoanatomy of the airway, a key landmark points in identifying the difficult airway. Dear friends, do you remember HMT wristwatch? It was the only brand before Titan came in the picture. Do you remember the Kodak camera? It was having the film which we used to print out the pictures. Do you remember the Nokia phone 6113? It was the best phone at that time in the market. Those why are big? First of all, I would like to sorry Rawat sir. I was consistently asking him that we need to reach fast at whatever the cost. Once Rawat sir is a military man, he will never forgive us. So sorry. So coming to the point, today this topic, actually there are very few and identifiable findings to be learn, memorize and get worse with that, and that topic is a very small. Time allotted to me is a very, I think 30 to 40 minutes, but still I try to cover that. Okay. The learning objectives for learning objective for the identification of the major airway. So sonography is a easy tool to use bedside portable machine to identify and locate the structures in the body. Rather than going deep into the history of the sonography, everybody nowadays knows it has a screen, it has a 2 to 3 probe, those are called as transducers, and with that transducer, keeping the media in between the skin and the probe, we can go to the deeper structure and identify how and what they look like and find out the pathology behind those. So, objective for my today's lecture are to learn, identify the major airway related neck structures that are located in the anterior neck, then recognizing esophagus and the trachea, differentiating between that to identify intubation, esophageal intubation, and understanding the dynamic maneuvers like swallowing or jaw movements. Those will show us to identify the size of the tongue or location of the esophagus. This knowledge will be applicable in the emergency as well as bedside screening for the difficult airway. Coming to the basics. So, in basics, we have linear probe, which is having frequency to 5 to 15 megahertz, then curvilinear probe to see the even superficial structures, and those are located in the anterior neck. We can easily find out those. And the third one is a 2D echo probe. Now, ultrasound. Okay, key anatomical structures we will find in this are the thyroid cartilage, epiglottis, then cricothyroid membrane, cricoid cartilage, and thyroid cartilage. After the thyroid cartilage, it comes a cricoid cartilage. In between that cricoid membrane and after cricoid cartilage, there are the tracheal rings and trachea. So our field to identify is right from the hyoid bone, then thyroid cartilage, thyroid membrane, cricoid cartilage, cricothyroid membrane, and then tracheal rings. It's a very simple thing that you can go easily there are very few things to identify and keep in mind while doing the ultrasonography of the upper airway. That is, figure will show that where to place and how to place your transducer or the probe. Okay. To go for the submental sonography, you can use your probe in a long axis. Actually, this is theoretical part will be shown here on the screen, but actual things to be understand that will be done on the actual hands-on. Right? Manually. So the orientation while doing the sonography, when we are using, sorry for the interruption, orientation while we are doing the sonography, if we are placing the probes transverse, that is transverse axis, horizontal probe, and then if we are keeping the probe in a longitudinal axis, that is vertical. If we are placing the probe transverse in a supra thyroid or hyoid area, we can identify the hyoid bone, then thyroid cartilage, then structure behind the thyroid cartilage, they are the vocal cords and all. If we slide down the probe little bit caudally while performing the sonography from thyroid cartilage to the downward side, we can easily see a thyroid cartilage, then cricoid cartilage and tracheal rings. Then if we place the probe in a long axis, we can identify the structures as I told right now. Identifying the cricothyroid membrane is the key. That is thyroid cartilage, the membrane between thyroid cartilage and cricoid cartilage. A thin white line can be seen on the sonography. Esophageal identification, if we place the probe on the thyroid cartilage and slightly pressing it and in either direction, right or left, we can identify the thyroid gland in front of the trachea and then vital structures like carotid artery and IJVs. But if we see just posterior to the trachea, we can see a small structure while doing a dynamic sonography, that is asking patient to deglutinate something. So we can see the collapsible structure behind the trachea. Those are the, I'm just explaining it, but you will come to know enough other slides. The identification of the esophagus is helpful in a future to identify the wrongly placed tube in the esophagus. This figure orientates you about the placement of the probe. Number one, it is showing a probe in a longitudinal direction, that is above hyoid bone. Then second number shows placement of the probe horizontally in a hyoid bone to thyroid cartilage. Then third one, horizontal placement of the probe on the thyroid cartilage, where you can see the structure like vocal cords, anterior commissure and epiglottis in this view. At the number 4, it had shown plus sign, that is probe can be placed in a longitudinal direction as well as in a horizontal direction, so as to identify the cricoid membrane or space behind the cricoid membrane. And lastly, 5 number shows placement of the probe horizontally below the cricoid cartilage, that is in between the tracheal rings. This is to identify the space while doing the percutaneous tracheostomy. Now, one by one we will go towards learning how to place the probe. The picture A shows the placement of the probe horizontally, that is in a transverse position below the mandible and sliding slightly towards the hyoid bone. That A figure will show the hyoid bone here. If you are identifying this marked line in a yellow arrow, the distance from the skin to hyoid bone that will be measured, and this will be helpful in identifying the difficult airway. I'll tell you in a further slides. Now slightly moving the probe in a corded direction slowly at the point where you can see the placement of probe in a suprathyroid cartilage region. Here you can identify the little black line, that is epiglottis, and the yellow arrow that is showing the distance from skin to epiglottis. Okay. Then slide has moved. Then third one is the placement of a probe at the vocal cord region horizontally. This will show, or you will be able to measure the distance from the skin to anterior commissure of the vocal cords. Here the white spot, are you able to see this white spots? Here you can see the vocal cords here in abducted lines. These are vocal cord ligaments, and the black thing below this hollow arrow is the air interface produced by the air in the trachea. So how you can use these findings to find out the difficult airway? A recent study conducted by Dr. Avinash Dole at SMBT Medical College only. He has found out the difficult airway by calculating the distance from the skin to epiglottis and distance from skin to hyoid bone and distance from the skin to anterior commissure of the vocal cords, and he found that the distance from skin to hyoid more than 1.5 or distance from skin to anterior commissure of the vocal cords, that is more than 1.3 centimeter, it will be having a difficult laryngoscopy in obese patients. Then there are a lot of studies are going around the world to use this sonography as a tool to identify the difficult airway far prior to the patient taking on the table. The optimal cutoff they have used here will again be, we'll see in a further slide that another study they have shown how to use the tongue size to identify the difficult airway. Now coming to the next slide, a transverse approach, that is TACA, method, thyroid cartilage, airline and cricoid cartilage. Okay, here in a figure 1 you can see the probe is placed horizontally on the thyroid cartilage here, and you can see a thyroid cartilage here as a white dotted line. Then below that the vocal cords and the black space created by the air in the air inlet. Now the airline where we identify as a, are you able to identify this black, white line here depicted with a blue arrow? That is the cricothyroid membrane, and below that there is a space filled with the air that will be a space behind the cricothyroid membrane. Sliding down the probe little downwards at the cricoid cartilage, it will be seen more dense white because the ultrasound waves are not able to cross this cricothyroid cartilage. That's why it is seen as a white, and the air reverberation are seen below that. Then if we see the airline behind the cricothyroid membrane, this will be used for the a tool to use for cricothyroid puncture in a emergency airways. Coming to the next, longitudinal as well as horizontal, that is transverse axis. Placement of the probe below the thyroid cartilage. Are you able to see this homogeneous structure on the either side? This is the thyroid gland, and the line seen as a inverted U, that is a thyroid cartilage, and if we slide little laterally towards the left side from the trachea, you will be able to identify vascular structures, that is carotid artery, and below that, if you rotate our probe and make it vertical, that is in a longitudinal direction, you will be able to see the first the thyroid cartilage, and then cricoid cartilage, and the rest of the cricoid rings seen as a pearl of string. This one, this one, this one, this one, this one. Okay. These are the things to identify. One more thing I would like to show you by calculating the diameter of the airway in a particularly in a pediatric patients where or a neonates, where you will be able to calculate the size of the tube which you can put into the airway. Another thing, this is a trachea, and you can see the collapsible structure beside the trachea. This is the esophagus. Whatever I wanted to show in a previous slide, it is best seen here. And the vascular structure, those are the carotids seen here. So, subglottic transverse diameter in a UHG in a transverse probe, that will be calculated. The distance between those 2 points will be equivalent to the diameter of the curved tube, and you can there are the things this criteria can be used to calculate the perfect size of the tube to whatever the age and height related formula is there for the calculating of the tube size. Now, how to identify the successful placement of the ET tube in the trachea or where it is? As I shown previously, a U structure seen over here, it is a trachea, okay, and air interface seen inside here. But if you are not in the trachea, your tube has went in a esophagus, there will be another structure seen beside the trachea, that is called as a double shadow sign or double Newman sign. That will be seen over here. Friends, it is really, I can't say it is a very tool to be used in an emergency situation, because tube in the esophagus and then you will put on the probe. It is not like that. It is to be done in a dynamic usage of the ultrasound while you are doing a intubation in a spontaneous, and you are placing the probe at the same time in the anterior neck and finding out whether you are entering in the trachea or esophagus. So another study that coming up nowadays is a finding of the presence of arteries in the tongue, that is glossolalia. These are the 2 pointers. You can see the arteries seen in this is the tongue. When you place your probe in a submental region, and you can use this as a marker for the finding out whether the patient will have difficult airway. Now another one is the post extubation stridor. This may be used as a tool to identify which patient will go in a post-extubation stridor. The technique used over here is while putting the tube, you can check the diameter after inflation of the cup and after depletion of the cup. The leak test will be used to identify whether this patient will have a stridor or not. Then assessing difficult airway, those are the things which can see tongue thickness more than 6 centimeter, hyometral distance less than or equal to less than 5 centimeter, hyometral ratio less than 1.1, soft tissue thickness at the 5 bone, it is more than 1.69 centimeters, and soft tissue thickness at the thyroid membrane, that should be more than 3.5 centimeter. Palato-glottal space, nowadays people are working on this to identify which patient will have a difficult mask ventilation, even difficult intubation, difficult laryngoscopy, those are the after things. But if we are able to identify the difficult mask ventilation itself, then we will be far ahead of the others. That thickness of the tongue to be measured by placing the probe in a slightly extended neck, as shown in the figure, and identifying the space. If you are able to see this is the palatoglossal space in a transverse probe and in a linear probe and in a curvilinear probe. It is having specificity of up to 95%. It can identify those difficult mask ventilation. You can see how they have placed the probe over here and see the distance between the soft palate and the tongue. This is beautiful study. They, Mr. Sarath Sekhar and et al. Have conducted this study to identify the difficult mask ventilation. So they have studied almost 142 candidates to find out whether the criteria calculated on the sonography are they matching with the patient while they are inducing or not. So they have found that it has a sensitivity up to 84%, and in 84% of the individuals they have found that those candidates who are having less palatoglossal distance, they are having difficulty in mask ventilation also. So this study is really beautiful to get away from the condition can't ventilate and can't intubate. Another, this is the same slide, how to find out the palatoglossal space over here. So we are approaching towards the end of my session, where we are using the pre-glottic soft tissue thickness, where we have seen lot of people with a large chin or the obese or having BMI more than 35. You can see the placement of the probe here. Also they will show the thickness of the subglottic area, pretracheal soft tissue, then distance from the skin to anterior commissure and itself. Vocal cords are difficult to achieve. The difficult airway assessment is really a notorious to identify the difficulties in predicting the difficult airway, but experienced hand on the USG assessment can be done in a few seconds if we practice it in a daily, day-to-day practice. The combination of the approaches are more powerful than a single one, and no suggestions that this should become the common practice in every institute, or every clinician should have expertise in this. But availability of the ultrasound machine everywhere is a very important thing. So, vocal cord, another use, what we can use this USG machine in a bedside or bed table or OT table. The pre and post neck surgery superior laryngeal nerve function visualized in the young females actually. Many of the times surgeon ask us to, after removing the tube after large thyroidectomy, to see the vocal cords. And many of the times there are lot of things in our mind also whether to extubate this patient in a deep plane to see the vocal cords or let the patient get away. The USG machine can solve this problem. You can see a percutaneous vocal cord movements of the USG also. Then use of the USG machine for LMA placement is another use. It's locating the epiglottis and the superior laryngeal nerve. As we are using USG machine for lot of blocks and everything, USG machine again can use in blocks for the upper airway, and the most useful airway block, that is superior laryngeal nerve, can be given USG guided, as the superior laryngeal nerve lies very in the vicinity with the vital structures like carotid and vital blood vessels. So, USG machine can be used for the giving blocks also. While concluding, lot of potential uses, but sonography is a non-invasive, non-radiating, easy to handle and portable bedside tool, can be used for identifying and managing a difficult airway in any situation. Those are my references, and I conclude with this lecture. Thank you.